Hello everybody, this is Roisin Breen here in Dr. Stephen's Hospital, and I'm delighted to have Dr. Anne Kilgallen with us today from Northern Ireland. Anne is going to speak to us on creating work improvements conducive to continuous improvement. I hope you can all hear okay and the sound is transmitting all right over to you. You can use the chat box in the top right hand corner to type in any questions or comments as we go along. So Dr. Kilgallen, just to say a little bit about her, she's a consultant in public health medicine, and prior to taking up the post as Chief Executive of the Western Trust, she worked as Deputy CMO with responsibility for population health in the Department of Health in Belfast. In 2014, Anne undertook a QI fellowship 1 year based over in Boston in the Institute of Healthcare Improvement, where she had an opportunity to study international healthcare systems that have successfully brought clinical leadership, improvement science and systems thinking together to transform care. Prior to her fellowship, Anne served for 6 years as Medical Director in the Western Health and Social Care Trust, and she actually went to college down here in Dublin in NUI, completed her training in public health medicine, did an MSc in NUI in '95, and from Harvard University in 2016. A long list of accolades, so we're delighted to have Anne with us today. And just a short bit of housekeeping, we want to keep it as interactive as possible. So there is a phone number there on that slide, sir, so you can dial in. It's 015260058, and the event number is 840-630-964#. And we will have time at the end to have questions and answers with Anne. So if anyone has any questions, comments or queries, please put them into the chat box and we have time to deal with those at the end. So without further ado, I'm going to hand over to Anne. Thanks a million, Anne, again for coming to speak to QI Talk Timers today.
Hi, Roisin, and good afternoon, everybody. It's an absolute privilege to be speaking to you, and I hope that some of what I say is of relevance to you in your daily work and indeed helpful. I'm going to start by saying just a little bit about where I work, because clearly it influences how I behave and what I'm doing in my current role. I'm responsible for services, all of the health and social care services, apart from those based in general practice. And the area that I serve is that area in gold on the map, with about 300,000 people that we serve, although for some of our services in Derry, we provide trauma and orthopaedics, we provide cancer services, radiotherapy specifically across border, and we also provide primary PCI across border. So for some of those services, we serve up to 500,000 of a population. So with a very complex organisation here, a lot of people involved, a lot of people we serve, and I would imagine reflecting very much the space in which many of you listening are working to. So very varied, very complex. So this is my disclaimer. I spent a year, as Roisin has said, in Boston working, studying with the Institute for Healthcare Improvement, and that really has shaped my thinking about my work. It's given me a lens through which I understand the world in which I work and the people I work with and the people we serve. And so that is my disclaimer, but it's also what has really, I think, made me a much more effective practitioner and really influenced for the better what I do. So IHI, many of you probably know, IHI was set up in the late 80s by this man who's a paediatrician, Don Berwick, who was entirely frustrated at the error rate in his service and the difficulties, the challenges in learning and improving. And he attended a seminar by a man called J. Edwards Deming, statistician and engineer, who had been responsible for the transformation of Toyota car manufacturers. And from that seminal moment, Don and a small number of colleagues, there were 6 of them, decided that they wanted to test the translation of improvement science as it had been developed in industry and in manufacturing and in the business world. They wanted to test how that might be applied in healthcare. And from that day to this, they have been experimenting, learning, testing with a range of strategic partners across the world. And I'm going to tell you about some of what I saw while I was with them that persuaded me that this could really transform the care that I'm involved in providing. So IHI is founded on an unshakable belief in the idea that each one of us really has 2 jobs when we come to work, both to do our work and to improve it. But if we're ready to fulfill those 2 functions, we need support. And of course, most of us will recognise we don't work in isolation. We generally work as part of a team. And so a lot of what IHI has been focused on has been on understanding what makes for a really high-performing team and what systems are best suited to supporting teams to be the very best they can be. And what IHI and other organisations across the world have begun to identify is that teams work best when they've got shared purpose, when they're really driven to be the best they can be, when hierarchy is only enough to get the job done but not to get in the way of doing the job, when they practice together, and that means they've shared language and shared toolkit, a shared approach, but also intentional design. And so much of what I have learned has been about the need to stand back, think carefully about the person we serve, and to think about the design necessary to actually meet their needs rather than what we perceive to be their needs. So I'm just going to share with you some examples of, one example in particular, of the system that I saw when I was with IHI, from which I really learned about improvement and the constituents for work environments that really assist and encourage people to improve. So there are three of these systems, and they're each very complex, each different in its own respect. So none of this is simple or indeed simple to translate. And so some of what I'm telling you is, if you like, a little bit reductionist. I'm giving you, distilling what I learned, but clearly, as all of us know, when we work in our own environments, there's great complexity there. But I want to share with you what I learned. There were three systems in particular that have influenced me. One is Cincinnati Children's, which is a quaternary system responsible for providing primary care needs, but also very complex needs for children up until the age of 25. NUCA, I'm not going to say much about, but it is a primary care system, South Central Foundation in Alaska. Very similar learning from my experience there, even though they're providing for a very different population of about 70,000 of the very often most deprived native Alaskans who rely on them for care. And the third system that really impressed me was in Sweden, based around the province of Jönköping, and that again is a system designed to meet needs right across the life cycle. In particular, they're famous for their work for older people, what they call the Esther Project, and Esther is an elderly woman, and her needs and her perspective defines the work that they do. So since I was there are many systems, particularly in Scotland and in England, which have come to the fore, but these three particularly impressed me, and the one in particular that I'm going to focus on is Cincinnati Children's. So on my fellowship, there were a group of 10 of us, and 6 of us got to visit Cincinnati, and these are my colleagues. So what I wanted to share with you about Cincinnati was, first of all, their narrative about why they needed to change. So they, in the late just the turn of the century, it became clear to them that their care for children with cystic fibrosis was not as good as they anticipated or thought it was. And that really set them to thinking about, in particular, their in-hospital care and their ability to recognise the deteriorating child and to respond appropriately. So they looked outside their organisation in the first instance, which is why you've got this Naval Air Force pilot. They looked at naval warships and where planes are landing and taking off, and looked to learn from them about how they manage complexity in that environment and translate that then back to their system in Cincinnati. And so the sort of tools and techniques and approach that they recognised as being the key to success on the naval ships was frequent pre-briefs and debriefs, using checklists appropriately, flattening hierarchy, which is such a constant theme for us. It's constant for me in my work, and I'm sure for many of you listening. Standardising communication so that there's a language and a toolkit which everybody understands, huddles and situational awareness. So Cincinnati then, the team from Cincinnati then focused on translating what they learned from a completely different business and applying it in their world. And so what you notice in Cincinnati is huddles every day, first start of the day at every level in the organisation, culminating within an hour from the start of the day. There's a huddle, cross-organisation teleconference with the chief exec, where the chief exec is apprised of the latest situation in the acute system right across the Cincinnati system. And in order to make the huddle work, they had to identify the 5 key risk factors that they were going to focus on, and you have them listed here. The one which really got me was the watcher gut feeling. Any staff member on a ward is free to say, I'm concerned about this individual, it's just a gut feeling I have. And that kind of freeing people up to raise concerns without a fear of criticism or undermining is really powerful, and you really feel it when you're out on the wards in Cincinnati, their commitment to hearing every voice and to really understanding where risk lies. And then they have a mechanism for responding with a patient safety officer of the day. Now, as I've said, I'm giving you an insight into one part of their organisation, but in fact, at the time I was there, Cincinnati was doing some really innovative work in relation to children who rely on them for care for asthma, and they were hotspotting, looking to see where the bulk of their referrals come from, thinking about providing community outreach clinics, thinking about the kind of housing and other needs that people have locally which might predispose their kids to respiratory tract disease and infection. So my point is that although this is just one part of their response, this attitude, which is about really liberating staff to be inventive, to improve, but doing that in an organised way, has had all sorts of benefits for them over the last decade. And although they started in one place, and indeed this is the data which shows the impact of this effort, they were able to reduce their serious safety events by 80% in that decade leading up to 2014, and have sustained that since. But because of the culture that has ensued, they have become much more serious about improving their care right across a whole range of opportunities. So, from the 3 systems that I've identified to you, but I suppose most easily typified by Cincinnati, the observations that I made about really successful systems, systems which really improve and support their staff to improve, is that they all have a burning ambition, but they're clear about why they're doing this. Can-do attitude, it's very American, but in fact, what I recognized was that the staff are commissioned to test, and there's an agreement about safe ways to test. So those of you that are familiar with the PDSA, you know you don't have to set up a new clinic. You don't have to set your reputation on your idea being the only one that's going to work. You can test with the next person. You can test once and you can build on that test. So it's very, very much safer than our old model, which was to set up a pilot. Once you set up a pilot, your reputation then lies in the success. So in addition to tools that allow people to test, this ability to look outside, to being open to learning from elsewhere, just as you are, all of the people on this call, all of us keen to share our learning. They have a shared approach, and those of you who are immersed in quality improvement will know the value that that brings. Experts, just enough to support the work, and infrastructure. And by infrastructure, what I mean is, for example, the arrangement around the huddles. That's an infrastructure which nudges people, encourages people to do the right thing, and it's really essential if you're going to hardwire improvement so that the environment is really conducive to improvement at every level. So what this taught me, coming to this post as I did about 18 months ago, and indeed before that when I was working on our regional system for improvement, there are 4 key messages. One is about the real importance of us being in this together, being clear about our shared purpose, the need to develop people, to develop skills very specifically, but also to address the behaviours that allow people to be the best they can be, allowing people to raise concerns, allowing people to ask questions, and for that to happen in a way which doesn't bring with it defensiveness or a sense of failure. And then this issue of a supportive infrastructure, which can mean having experts available, but can also mean having regular touch points, be they huddles, be they other arrangements, which encourage people to focus on improvement, which encourage people to share learning. So we have spent quite a lot of time really trying to engage with people about what motivates them, what they want to achieve, what is your why. And as a result of that, we've identified a shared purpose with 4 key themes, really aligned to the biggest needs that we see in our population. So focusing on a great place to start life, and in particular for children at risk, because we're corporate parents for children who come into care. So really focusing on children who are at risk that we want to intervene early with to support them and their families. We'll focus our second theme on a great place to live well, which is primarily about people with long-term conditions. So making sure that our services are as well designed as they can be to meet the needs of people living with diabetes, living with heart disease, indeed living with multi-morbidity. And a great place to grow older, and a key priority there for us is focus on our work for people who are frail. And the idea behind these themes is that we move beyond the hospital walls, or indeed beyond the constraints of a community team, and we look to work in a boundaryless way, moving across interfaces, making sure our services are designed for people as opposed to for ourselves. The final theme, the great place to work, is the one which has resonated most with people. And again, in organisations across the world that are successful at improvement, they all start with a sense of empowering their workers, of supporting their workers, of ensuring that the environment is as supportive of them as can be. And we have found that that has really, really gained traction in this organisation. So the approach that we've taken, having identified those broad themes through conversation and investigation with our staff, we've taken a number of approaches then just to freeing up people, to bringing diverse groups of people together, to really explore what it means to have these big, hairy goals and yet to connect that to our daily work. So we've had discovery groups, which have people who've volunteered, small numbers, 10 in each, and we're into our second. We have 4 groups at any one point in time. We're into our second cohort. And we've just asked them to take the themes, to connect with staff, to look for good practice, to share good practice, and to begin to model teaching and learning together. We have, of course, focused on quality improvement. So, and I'll say a bit later about the fact that we are standing on the shoulders of people who've been in this organisation before us and who continue to work individually and in teams to improve care. So we focused on individual. We're fortunate that we have, as you have, a national framework for improvement. So we have agreed what we expect people to understand. We have an agreed core curriculum, we have e-learning, and we now have individual training programs across all of our organisations which focus on developing the skills of teams. And then in my organisation, we've been really fortunate to get funding to build on the team-based approaches using a methodology called flow coaching. And really that's focused on redesign of a pathway. So the team is a team required to deliver a whole pathway of care, so much broader, stretching the boundaries of what we normally do. And those people come together for an hour once a week to work on a pathway development for specific patient or client groups. And the first 3 pathways that we've been working on are care for women who develop gestational diabetes, the pathway for people requiring primary hip or knee joint replacement, and then a pathway for people who are frail. And each of those groups of people are people for whom we feel we could do a lot better with the resources we currently have. So that's our focus on a structured approach to quality improvement, and it includes attention to PDSA, it includes attention to using lean tools, but it also focuses very much on behaviours and attitudes and empowering people to question and to make small tests of change wherever they are. And the final example that I give you is our focus on people. If there's one message I would give you, it is that the greatest agents for change are the people we serve, people who rely on us for care, whether you call them patients or clients or service users, their carers and their families. And so we're working hard to understand how we can involve them better in the work that we're doing. And we're fortunate that they have been involved in the big rooms working on, in particular, the frailty pathway. I realise I'm going very quickly through all of this, but I want to say that what you've heard in that previous slide is the views of a system leader who's got a theoretical knowledge of what a successful system requires and is working with as many people as possible to make that a reality. But The real challenge, though, is to recognise what moves people at a very local level. And I wanted to refer to PJ Paralysis because I was at a meeting last night in Antrim, and we with Brian Dolan, and he shared data with us from Waterford and from St Luke's in Kilkenny, where, and I'm sure there are other places where fantastic moves are being made to get patients out of their pyjamas, get them into their clothes, and to really tackle the whole agenda around deconditioning that happens in hospitals, particularly for older people. And the reality is that on the ground, without me or anybody close to me taking a single step, what we've seen is people really motivated to get on board with this movement and to really make a difference at ward level. And you just can't beat that. No amount of thinking good ideas really connects with people as much as what matters to them at ward level. And that campaign has been particularly successful. And the other one I want to mention is at Better Bowman. I had the privilege in 2016 to go along for a lunchtime session there. A couple of us travelled from Belfast, and I follow Better Bowman on Twitter, and what happens in Beaumont I think is remarkable. And we have tried to create something like that here by having a lunch and learn. It just hasn't been as successful. So I'm still waiting and hoping and working to try to create a dynamic like the Better Bowman movement. And the point I want to make is that no matter how much while we talk about intentional design, people's hearts are the starting point for most of their discretionary effort, and these are examples of movements that really transform care, and I'm so grateful that they exist and that we can learn from them. So just to say a little bit more then about the team-based working, and I wanted just to speak about a team. This is one of our mental health teams, so we've very diverse services. And I suppose I wanted to explain, just to take the opportunity to say that none of us work in a vacuum, that really when people are intentional and improving, you're often building on ideas and practices that they've used in the past. And this is a particular example of a team who've been working since 2011 to improve their care, but have probably not had a shared language or clear language about how they were doing that until about 2014, when they began to learn formal quality improvement tools and techniques as a team. And I wanted to share it with you, firstly to say it has nothing to do with me. It existed before I arrived. But secondly, to show the power of teams when you really engage with them and with what matters to them, and provide them with the tools and techniques to influence their environment, take control of their environment. So the team have fed back that through the work that they've done, in particular with the quality improvement training, that has really allowed them to make decisions in a much better way and to solve problems together. They've developed new skills and they have a strong sense of achievement. For us as an organisation, I want to show this example, which is their ambition to have team members attend at handover. And what's really important about this picture is where the blue line flattens. Up is good. I should say that up is good in true improvement language. Where the blue line flattens to the right of the picture in front of you, it says 8 a.m. start. And that's the point at which the nurses agreed to change their shift pattern so they would start at 8 o'clock, so that they will be available to join a handover which I think happens at 8:30. There's absolutely no way that a staff group would have agreed to change its shift pattern unless they really understood and agreed with the purpose behind the work. And I think that's a really powerful testament to the value of team, and particularly teams that use quality improvement. And then from the organisation's perspective, one of the key achievements for us has been their working together. They've been able to reduce the bed days that they use to deliver care, and it's been a really significant achievement. What's also interesting is that we have an organisation which has many different services, and it's been really difficult to get the message out from this mental health team to really share the learning, even within my own organisation, to share the learning of the achievement of this team with the wider organisation is quite a challenge. So it's something we have to stick at. One of the key things I feel I need to say to you is that my own belief is that whilst all of this, both theory and practice, where we see it is great to learn from, actually the only behaviour that I can change is my own. And so what we have done as a team is we enlisted the person who supported the team in Grangewood, the previous slide I showed you, a team coach. We asked her to help us as a corporate management team to learn together to improve how we work. And so that's been really useful, it might be useful for some of you. It's been a really useful way for people to learn about quality improvement. Busy people that would never be prepared or able to give up the time to go off to learn about quality improvement in a formal setting, but we learn by doing. So we've asked a coach to come along. We've been doing very practical work about our meetings, our agendas, our use of email. At the end of this month, we're going to test an email-free day for the whole organisation. The difficulty for any organisation is that how the leaders behave dictate behaviours and attitudes across the whole organisation, and we're swimming in our own water. It's difficult for us to see. So we as a group agreed that we would take advice, take a coach, take help from outside, and use that both to learn and to improve together. And I believe that both now and into the future is making a big difference to how we behave outside of our own team. And so just to summarise the behaviours that I think really matter, in particular for leaders, is seeking feedback, sharing information, asking for help, talking about errors and experimenting. And I've taken this list from Amy Edmondson, who's done a lot of work on psychological safety and learning. So I wanted to share that with you because I can feel and see within my own team that we are much more open and much better able to work together as a group, and also much better able, I think, outside of that team setting to question and to be curious as leaders across the organisation. So one of the areas that I have really struggled is the whole issue of infrastructure, and certainly having the resource to free people up to train, because we do need a small number of experts if we're really to sustain and guide and improvement across the organisation. But more importantly, having a drumbeat such as I saw in Cincinnati Children's, where they had that daily huddle. We have a daily huddle here. We meet as a team, but for the moment it's just our corporate team that meet, with people joining us from time to time, but it's not a whole organisation huddle. So the challenge for me is to find our drumbeat as an organisation. We're still preoccupied, as I would say most of you are too. We're still preoccupied with failure. We have systems for addressing complaints, we have systems for addressing incidents, and of course we must and should do. It's really essential that we do. But our systems for sharing, learning about improvement, for focusing and talking about improvement are more ad hoc than I'd like them to be. So I think until we crack this, and we're still learning, I think until we really have a drumbeat in the organisation, we're going to have to continue to be intentional about recognising and celebrating improvement where we have it. I think visual display, like these pictures, is incredibly powerful. And I'm going to say that to you, any of you that are doing improvement, however messy it is, and it's always going to be messy, absolutely, no doubt about that, but putting a board somewhere where your team can recognise its own work, where a visitor, in particular someone like me, can come along and know immediately what matters to you as a team and comment and question, is very, very powerful. And every organisation that I've been in which is really successful in this space, which is really transformed, this is what you see all over in different contexts. And I think it's really powerful, not just about showing the improvement in your work, but also in creating that environment and that culture where it's okay to examine and problem solve in a very open way. And that's at the heart of improvement. So it's a statement of the obvious, but many people will know James Reason's work on the Swiss cheese model, the reality that we are very human and human factors influence so much of what we do. So the whole point of my purpose is, and my job, at the heart of my job, is to make sure that the conditions in which our people work are the best that they can be to support high quality care. So finally, I just wanted to summarise what I think might be valuable for those of you who are listening. For leaders, what we pay attention to gets done. I believe leadership occurs at all levels, and I would suspect, I imagine, that everybody on this call has somebody who looks up to them. What you pay attention to is noticed by the people around you. So be curious about what's working well. I read recently somebody exhorted us to ask when something goes wrong, not just why did it happen, but why has it never happened before? Because by asking that question, you begin to uncover the good work that normally keeps all of us safe and our patients and carers safe. So be curious about what's working well and why. Listen, you can never listen enough. Reflecting on my comments about PJ Paralysis, or indeed at Better Bowman, go where people's passion is. I want us to be better at providing care for frail older people. I definitely want us to intervene earlier for children and their families to support them. But the starting point always has to be what moves people, what moves our staff. And again, from what I've seen across the world, if you start from there, it doesn't take long before you can build on that and be more strategic about where you put your energies. Opportunities to bring people together. I told you about our discovery groups. I personally have found that really an exciting place to be. It's made for very exciting conversations in our organisation, bringing people together who don't normally come together. It's been effortful. I noticed that how we do things around here isn't entirely conducive to bringing people together, particularly across different levels in the organisation, and that's part of my point about the drumbeat. My ambition would be to make it easy for people to convene, whether, as we're doing now, by video conference or by other means. So I wouldn't underestimate the opportunities, the value of creating opportunities to bring people together. But one thing I've learned, and I would caution you on this, is bringing people together to talk about improvement. Really, which is where I started when I first came back from Boston. I got together a group of people just to talk about improvement and to learn together about improvement, and it petered out. But if you bring people together to problem solve around something that matters to them, like the ethos behind PJ Paralysis, like the ethos behind Better Bowman, like the ethos that is in one of our teams around improving our care for frail people, that's when you really see people learning together. And it goes without saying, being intentional about developing expertise. And what I mean by that is no matter what team you're in, you will recognise people who are really skilled at motivating others, and they're the sort of people who might be worth developing some expertise in quality improvement, because they'll definitely have the skills to connect, the interpersonal skills that matter. So for teams, back to what I've said about the data, tell your story. It's an absolute draw. Narrative is so powerful, and that's been a difficult change for me to make as a public health doctor, because all that I know about evidence, although it does give place to narrative, I think I've really had to learn how to use stories to transform and to bring people with me. Maureen Bisognano at IHI talks about, she talks about see, solve and share. So she says, see a problem for one person, solve it, and then share that, solve for many by sharing your solution. So tell your story, make it easy for people to understand what you've done and understand your progress, and that's the visual display. Data, I just can't overemphasize the value of data, and we're really learning and sometimes struggling. We're drowning in data, but having the kind of data that really tells the story of improvement and focuses our efforts is, particularly at a system level, that is a real challenge. But when I visit teams, I see data all the time that is really telling the story of their own improvement journey, and then involving the people who depend on you for their care. Last night when Brian Dolan was telling us about PJ Paralysis and about the campaign that lies behind that, he spoke about some people and in fact he may have said this of one of the Waterford or Kilkenny, but the idea of giving an information leaflet to families as soon as they arrive, indicating that their loved ones will soon be in their street clothes, and really involving them in the change, involving them and encouraging the staff to think differently about getting people into their clothes and getting them back on their feet. So I just wanted to say in Northern Ireland, I've been involved in developing a regional system for improvement, and that's really been about encouraging people to share learning, just as you're doing today in listening to me. And some of what I don't pretend, I've deliberately shown you an example of work that occurred before I came. I don't pretend that any of the good things or all of the good things that are happening in my organisation necessarily depend on me. What really matters is that we share even the messiness of what we're learning, finding opportunities to share. And this is ours in Northern Ireland, our quality improvement and innovation system. Quote from Steinbeck, you know, there are many possible paths we might take, but at the end of the day, when we look back, we've just had one life to live. Never underestimate, don't give up your own power. Never underestimate the difference you can make. There's always somebody watching you. There's always somebody who's going to learn from you. And if you already have a team who are prepared to come with you and support you and work together, then you've got something really, really rich to grow and to build on. I think that's me. Yeah, that's really me. And just to finish, improvement is really messy. The beauty of the PDSA is that you can do that messiness in a very controlled and simple way at a very local level. Don't let any messiness hold you back. Life is like that, and good things come from combining people in very novel ways, and I would encourage you to do that. So thank you very much. I hope that's been of value. I'm really curious about your questions, and I think your questions are probably going to teach us all much more than anything that I've said in the last 20 minutes or 25 minutes. So thank you.
Wonderful presentation, Anne, and so much food for thought. I think we're going to have to get you back again to go deep dive into some of those points you made. Just I suppose, you know, you talked about all the different things that you think are important in terms of creating environments for continuous improvement. You talked about leadership, you talked about team development involving patients, data, and I suppose all the different examples that you talked about there. And I have loads of questions, and a lot of them would be from my own perspective, so I'd be selfish to take over all the question time. So please, people, put them into the chat box there for us. One of the things I was interested in, you talked a lot about investing in teams and team development. Would you mind maybe expanding a little bit more on that? When you talk about teams, you talk about clinical frontline teams who maybe are working together on care of the elderly or working together, and do you offer out training programs to them, or how does it work?
Yes, so we followed a model. One of the leading trusts in this space has been the Southeastern Trust, led by Hugh McCaughey, and they have for the last 5 or 6 years been running a team-based training program, which we've copied. So essentially we invite at least 3 people from a given clinical area with an idea for improvement, and we train them in quality improvement, and they learn by carrying out their project together. I know that Hugh, when he started out, would have done individual programs, and people came along. So an individual came along with an improvement idea and then went back to work. So they would come do the training for a day and then go back to work and then come back a month later. And so we've all learned that much more powerful if we can actually bring 2 or 3 people from a team together. And so that's what we've done. So that would be, it might be a doctor, a nurse, and a clinical nurse manager, or doctor, nurse, pharmacist, or AHP and a pharmacist. It doesn't really matter who makes up the team, so long as they are people who are in pole position to work with others to make the improvement happen. And it means they have a shared experience of learning together and can support each other in the doing. So I feel very strongly about that is much more effective in the workplace. It also requires the manager or the leader of that program of care, that service, to recognise that they're devoting a significant resource. They're sending 2 or 3 people to a program, and they need to support the implementation when those people come back. So yeah, that's the model. Now the flow coaching, which I spoke about, which is a real breakthrough for us, involves 2 coaches in a room with all of the stakeholders, as many people as are prepared to come along to get involved in the conversation. And we have rooms full of people once a week for an hour. And so that's a different, so people do learn quality improvement together in that room, but the main focus is on doing the work, and they have 2 coaches that support that. So 2 different approaches to the team training. One more overt, the big room work is really about redesigning care, but using quality improvement in the room.
And I see online we have a lot of quality and safety and risk people, and also I know others online who are really interested in developing their own QI movements, like Better Bowman, say. And I suppose just from a northern perspective, do you have in organisations people whose role is dedicated to QI, or is this just that person who is, you know, who's got the passion and is doing it alongside their current day job? It's just in terms of sustainability and keeping this going, how do you link down into individual organisations and having that one person who maybe coordinates and keeps it all going?
No, and Roisin, you do need that. That's a real challenge for us. And if any of my people are on this call, they'll be rolling their eyes at this point, because we don't have enough dedicated resource for our quality improvement people. I mean, the model that I use is that when we train people to what we call level 3, so these are people who really have an in-depth understanding of quality improvement tools and techniques and data management, we expect them to give a portion of their time when they come back from the training program. So when they're released to do a training program at that level, we expect that they will give a day a week back to the organisation in terms of, so therefore that their service leader or manager is prepared to sacrifice a fifth of their time to do this work. Now we would expect them to be doing work in their own patch. So that's the mental model. We have then a core team, so we have a lead for the Flow Coaching Academy, we have a quality improvement lead who sits in our governance team, and we have some admin support, but it's very small, and we are on the cusp of, and that's a bit about infrastructure that I'm really challenged by. We have to free up resource in order to do this work, but we have to do that within the existing resources. So it is about reallocating and retraining some of the people we already have, or enhancing their skills. It's essential, Roisin. Long-winded answer. It's essential. We haven't cracked it, but certainly in terms of the training of people, then the ask is that when they come back from their training, that they must give a day a week to improvement, either locally or strategically for us as an organisation.
Yeah, interesting, yeah. And I suppose there are some questions here online. Valerie Toomey from the NRH is actually doing some work on this with us on creating a local network for improvement, and she's asking about, you know, how do you reconcile having a flattened hierarchy while maintaining clinical responsibility?
Yeah, so I saw that question coming in. It's the exact same as if you went down to the ED. If a trauma case comes into ED, today the team will be clear about their roles and responsibilities when they're at the bedside. So it's not an either or. People still have clinical accountability, but it's simply about being able to raise concerns. No matter how junior you are in the team. I mean, this is what we sign up for. We say that it's okay, no matter what level you're at in the organisation, to raise concerns. So it's not cutting across clinical accountability or responsibility, but it is giving people permission to identify opportunities for improvement or concerns. So it's not an either or. It's both. It's that team culture.
And that was something that came up a lot in the presentation around, you know, that empowering people and giving them a forum through which their voice can be heard. And you talked about the huddles, and would you be advocating that huddles should be happening not just at management level, but at ward level and at individual team level as a mechanism to, I suppose, allow that to happen?
So they're working really well in this organisation at ward level because they're really suited to a ward. So in some of our wards in the afternoon, they have a multidisciplinary huddle for about 15 minutes around discharges. Works really well because it's so purposeful. In a clinical environment, a huddle is so purposeful. You've got 20 people, 30 people in the ward area, or you have so many people that you're responsible for on your caseload. It can be with a bit of structure, and there's a lot of, you can download stuff from IHI about the structure of a huddle. People who do it, it takes a little bit of practice. It does take practice, and it takes the leadership of the ward manager or the team leader, but it really makes a team much more dynamic, and it shares information, helps to create that culture. It's one mechanism, but it is very powerful, and it's simple enough. It needs a bit of structure and leadership, but it does allow people's voices to be heard.
Another question from Judy, who's a quality manager down in Waterford Hospital, and she's asking about, do QI people liaise with risk incident management personnel heavily in your neck of the woods, I suppose she's asking, yeah. Yeah,
so they sit in the same place, and they're from the same team, and so our QI manager is responsible for our complaints. Now, whether the first approach to a team around improvement should be to pick up on something that's gone dreadfully wrong, that's a little bit tricky. What does happen is a team that is deeply concerned. Cincinnati, they were deeply concerned about what they were learning about their management of kids with cystic fibrosis. So teams do recognise, if they get a chance to stand back and look at a pattern, they can recognise incidents would be one of the ways of informing themselves about opportunities for improvement. I think in the first instance, you have to go where the passion is. But again, my experience is that when a team has a sense of achievement, then they're able to tackle more difficult stuff. But there's no reason why. We would certainly encourage teams to use complaints and incidents as a source of evidence or information or trends to enable them to identify opportunities for improvement, and some do.
Another question, that's brilliant. Another question from Valerie is how do you engage teams and the competing demands of the day? So I suppose it's that question of how do you give teams time to develop?
Yeah, that is very difficult. I mean, you can see my head going down. I mean, I don't have an answer for that. I'm absolutely certain that, so if we look at teams that have done very significant improvement work in this organisation, what you find is they use time better. So people who've done work around access, so quite a number of teams have done work around access where they had really long waiting lists and the team was becoming utterly demoralised, and they have streamlined their processes, and so they have learned how to use their time better. For us, the coaching that we're getting as a corporate team is all about using our time better. However, if I bring you back to these themes and them making it a great place to work, the plea that our staff are making is, you know, how can we free up our time for this? So it's a double-edged sword. People who can use improvement well to improve their use of time, but for you to get the headspace is challenging. And so we're on that journey. We're on that journey. How do we free people up? And
I suppose it is that thing of starting with working with the willing and setting up like that lunch and learn type thing for the people who, you know, who are really passionate about it and trying to build from there, isn't it?
Yes. Yeah, and showing, that's why the data really matters, being able to demonstrate that this group have done this work and look at the impact it's had on their use of beds or the delays in accessing their service or the joy, the sense of satisfaction in their job. You know, whatever the measure is, that is inevitably, along with the story, it's what you need if you're going to persuade.
Yeah, and another question from me, actually, Anne. You talked about the regional system for improvement in Northern Ireland, and can you maybe just give me a little insight as to how that works? Is that a kind of mechanism to try and connect people across Northern Ireland who are interested in improvement?
Yes, that's a system that we have tried to build from the bottom up. So we went out, I was working at the department when we had a ministerial directive or invitation to set up a regional system, because there'd been a report which showed that we weren't great at sharing learning across the region. So what we did was really go to the early adopters, and we engaged with people who were already making improvement across the, okay, sorry, something else come up here.
It's okay, don't worry, we can still hear you, it's fine, yeah.
So the challenge was we weren't sharing learning, and we know that. And so what we did was we went out to people who were already in the improvement space or innovation space, and we convened them, we brought them together, both by video conference and in person, and we established communities of practice, and they identified work programs. So that was the building block, was to bring people together, establish community of practice. So for example, a community of practice around public involvement. And we asked them to identify what do we need to do. So for example, training. So training service users in quality improvement. And then one of our trusts agreed to set up a training program, the Southern Trust, which has always been in this space around involving patients in improvement. They agreed that they would run a training program on behalf of all of us, and we would all send or invite people patients or service users to that program. So that's an example really of engaging people across the region and then having one organisation deliver the product so that we all come to their table. So that's the bottom up. The chief executives are hungry. We're hungry to learn once for Northern Ireland. And there's a bit of a challenge around that because you have to recognise local nuance, and we all know we can't force from the top, not for a minute would we be fooled. But we do have a real ambition to reduce variation because there is unwarranted variation both within and beyond our organisations. So the chief executives are really keen to support the improvement. And I suppose that's my point about teams, about what you can do to help yourself. Making it easy for a senior leader to recognise the work that you're doing and to give you airtime and to share and tell your story is really powerful. So the communities of practice have made it easy for the chief executives to see what's going on across the region and to talk about each other's improvement work. It's very early days, Roshi, and I don't want to sound overly optimistic, but
this forum actually is one way that, you know, we set this up with the intent of trying to connect people, you know, that we're interested in quality improvement as a platform for sharing learning and for, you know, getting speakers in to share what's working for them. So, you know, it's an opt-in, it's an open platform for people to log into, but it's just coming from a national perspective down, you know. But there's certainly been learning for us in our journey to date, but we're still going, and hopefully we'll keep going for another while. But Anne, there's actually I think that's all our questions, but lots of really good comments. Ruth Creighton has said, great presentation, really engaged by the conversation that has followed. Thank you, and many of the threads resonate, for example, engaging people, sharing the learning and training. Maureen Flynn has said, wonderful to see the balance and focus of shared purpose between people, us and the people that we serve. And Judy down in Waterford has said, really enjoyed, and she's a packed room down there, which is great.
Well, back at Judy, I saw some wonderful data from Waterford last night who are doing great work on ending PJ paralysis, so congratulations to you.
Well, we're sharing, it's all good, great. Well, Anne, look, thank you so much for your time. It was absolutely fantastic, and the webinar has been recorded and will be available on the QI Talk Time page, as well as the slide sets, Anne, if you're happy to share those with us as well. And just on to the next slide there, our next QI Talk Time is in 2 weeks' time, and I don't think the slide is coming up, but it's on the, it's going to be on action review. So after action review, so there'll be a series of 2 of those where we bring in practical examples of how that's worked in organisations and the learnings from that. So hopefully people can log back into that. The flyer will be going out next week for that. And that's it. So thank you very much again, Anne, for your time. Really appreciate it. Lots of food for thought there. And hopefully everyone will log in again to our next webinar in 2 weeks' time. Thank you very much.
Thank you.
Thanks, Anne. Thank you.